to invite Blake Anderson and Cole Zanetti as well to join me as a part of this panel. We want to talk a little bit about the healthcare provider's perspective on health at home and patient care. We'll go through a few questions, but first I'll tell you a little bit about who I am, and then Cole, we'll pass to you and Blake as well to give a little bit of your background. So I work for VA. I am a pharmacy practitioner by training, but now director for clinical tech innovation, and importantly, the immersive technology lead for Office of Healthcare Innovation and Learning. Love to get to serve veterans and think differently about how we deliver care and how veterans experience care. And I think the health at home perspective is really important. But Cole and Blake are doing a lot in this space. So Cole, if you would like to take the lead and do your intro now, that'd be great.
Sure. Hi, everybody. My name is Cole Zanetti. I'm a physician out of Charleston, South Carolina. I also work at the VA. Serve as a senior advisor for the VA Center for Care and Payment Innovation, as well as the VHA Innovation Ecosystem. I'm also a Chief Health Informatics Officer here at the Charleston, South Carolina VA. I'm a professor that teaches digital health at the Rocky Vista University Osteopathic Medical School, and really excited to be a part of this conversation today. Go ahead, Blake.
Yeah, I'm Blake Anderson. I'm an internal medicine physician. I'm in Atlanta. I have appointments at Emory and then also at the Atlanta VA, where I'm the CHIO, the Chief Health Informatics Officer. I do a lot of work in machine learning and natural language processing and other kind of forms of AI, and I do a fair amount of work. I have some kind of unofficial advisory capacities for, innovations and clinical decision support in the VA.
That's awesome. Thank you guys both. I'll pose a question and allow you to really just riff off of each other. I know we've had a lot of conversations about this, but from your perspective as providers and heavily integrated into the healthcare system, why do you think that health at home is important? Why is it necessary?
Yeah, we've had a lot of conversations on this, but I think the big elephants in the room with healthcare are no matter which health system you're a part of, space and staffing is a recurrent struggle, right? We typically don't have enough space for the growing patient populations that exist in certain areas, and staffing can be a struggle to retain in those areas to provide care in the way that we have traditionally provided it for a long period of time. So I really think that care at home initiatives are necessary to address appropriate evidence-based care that is convenient, no matter where the patient or veteran, in our case, is located, whether they're rural or whether they're in a non-rural setting. Convenience of care that could be provided in the home that's evidence-based, that could achieve better outcomes or equal outcomes is almost a moral effort that we need to continue to pursue as we expand our reach to facilitate better care.
I think the other thing is just taking a very high level view. Hopefully, most patients that we interact with, 99% or more of their time is not spent in front of a physician or other care team member. So by only focusing on the care that is, occurring, or the health that occurs when they're in front of us, we're missing quite a bit of it. And there's several examples of just how true that can be. Even something simple like how home blood pressure monitoring is almost always going to be more accurate than what occurs in the office, and that can have significant impacts on kind of what care is delivered. And this is obviously a very big topic. I think we kind of touched on some of the things. There's hospital at home, there's remote monitoring, and then a few other topics that I think Cole is going to touch on. But fortunately, a lot of these, in addition to the convenience, presumably higher accuracy, there's also fortunately a fair amount of studies that have shown improved outcomes with some of these kind of newer approaches.
I would love to, Blake, just build on that a little bit. When you say accurate, what are you talking about the tech accuracy? Are you talking about the clinical accuracy? Dive into that a little bit more.
Yeah, so, the blood pressure thing, I mean, I'm sure that many people on this call are familiar with the term, white coat hypertension, and that's kind of like a very basic example. Where you come in the doctor's office and your systolic and diastolic are both like 20 over, what your average at home, might be. And for the case of blood pressure, your average, over time and is likely going to be more important, more significant than, the whatever 5 minutes that you're getting your blood pressure taken in the office.
That's right.
Nicole, I think you've had a few things to say about that too.
Well, yeah, I mean, the studies on this are pretty robust. We've known about this for a long period of time, and it makes sense, right? You have multiple data points in a setting where someone is naturally existing the majority of their life, right? That you're able to look at as in context of prevention and early intervention. What the reality is that people interface with healthcare a very small portion of their life, and that information or insights, as you heard in prior conversations to ours, could be life saving, right? If we're able to intervene earlier when risk is identified, that's a life saving opportunity.
Absolutely. I think that is an important feature of health at home, where you think about we're actually getting to see and engage with the patient as they go about their daily life. We're getting a more accurate, as you said, Blake, a clear picture. So just taking that even a step further, what is the evidence that supports this type of approach?
So, since we don't have, 5 hours to go over this one topic, I'll try and focus on some kind of high level points. There's, and I found a few studies just talking about how many more studies there are about home health over the past few years, just for some context. But, there's been a lot of studies showing, similar to what Cole was saying, with the blood pressure, there's also for things like hospital at home, where somebody might be on the kind of verge of meeting admission criteria, finding ways to give them hospital level care at home. They have improved outcomes for obviously very specific situations, both, with readmission and quote unquote length of stay, but also some of the kind of more difficult to track outcomes as far as like anxiety related to the care, and then also, need for long-term nursing care afterwards. I'll let Cole jump in. Like I said, this is a very big topic.
Yeah, I mean, this covers evidence out there related to remote patient monitoring is pretty robust in different areas, even home-based primary care, right? Care in the home is not just through technology, right? Technology facilitates our care, and home-based primary care at the VA has been shown and studied recurrently, not just at VA, but in the private sector at large, to really help with multiple chronic diseases related to CHF, COPD, diabetes, and improve outcomes related to these components. But overall, the evidence of these opportunities, although exists, it's that next step. It's like, all right, we know that this can help people and in the correct way. So now how would we implement and scale this in a sustainable manner to really support the convenience of improved care?
That translational exercise, right? Going from the evidence to the implementation part is a big piece of the puzzle. What are some examples of how you guys individually in your clinical practice, at your medical centers, or as you've had oversight on some of the broader efforts across VA, what are some tangible examples of health at home care?
So, some of the, as is true with many people, a lot of the work I've done over the past few years has had a COVID flavor. So one of the programs that we stood up in my academic facility was trying to find ways to identify acute decompensation in COVID patients. And this kind of started fairly early on. And we went about this a few different ways. One was sort of like an event-driven automation, where patients were responding to surveys via SMS, and we were, intelligently trying to notify clinical care teams. We also took a dive into some formal remote monitoring using devices so that patients could have higher level quality, pulse ox and pulse measurements, so that they could kind of self-report some of these, potentially significant changes in their digital biomarkers. And I'll pause and let Cole step in.
Yeah, I mean, the VA fortunately has been a leader in this area for a long period of time. There are many reasons for that, but we have robust programs for chronic disease management, and telemedicine, and virtual care, where veterans are able to receive that care at home, including blood pressure management, diabetes, etc. One of the, I think, more innovative programs that I've been involved with, which we're starting to actually stand up here at the VA, is with a company called CareCentra, where their focus is actually building a unified personal healthcare algorithm for each patient that allows them to manage their health through precision nudging. And essentially, it's utilizing BJ Fogg's approach to persuasive technology, and figuring out over a short period of time the content, the channel, the frequency, the care setting, and the incentives that nudges would help facilitate healthy behaviors. And what we mean by nudges in this case is over that 6 to 8 week period of interfacing with a patient, the artificial intelligence is figuring out, is it a notification or an alert that patient responds to or engages with a phone call, a text message, an email, a snail mail, social media, voice. So it's learning over a period of time what is the engagement, timing, frequency, content approach for each individual that can be applied to any care pathway. So it's not just a disease-specific modality. It's any person with a chronic condition or post-surgical follow-up for rehabilitation can be engaged with this solution to follow a care pathway. And the evidence related to that has been pretty significant to help us navigate how do we approach this as a quality improvement approach. But how is this important from the context of in the home? It's actually wherever you are, right? It's the global scope of where you are in your life, because the timing of things might not actually be perfect in the home either. It might be in transition between work and home. It might be while you're walking your pet. And figuring out how and when to appropriately engage with a patient to influence behaviors like taking their medication consistently, going for a walk, increasing physical activity, or being able to more timely realize when someone might need a medication refill so that they don't go a few weeks without a critical medication, are all really important. So there's been great evidence related to this technology to support improvements in health outcomes broadly. So we're going to be working to implement this solution in the coming year, over the next year here at the VA.
Love that.
So,
Yeah. Go ahead, Blake.
I think one point that I think is important to think about from a provider perspective is the difference between kind of solicited versus unsolicited PGHD, patient-generated health data. And I think that CareCentra would be an example of, this is being provided by the healthcare team, which is, I think, is different than somebody just kind of randomly sending a message, a secure message with like, hey, I took 5,000 steps and I weighed, whatever, 180 pounds today. And I think that one of the reasons why I bring this up is the potential impact of information overload, and why coupling some of these solutions with machine learning and AI and other kind of tech buzzwords is important, so that we don't become victims of information overload, especially when there's already kind of a pandemic of provider burnout related to all the administrative tasks that are present in the EMR. And
Yeah.
now I'm kind of going off the rails here, so I'll pause.
No, that's an important point, because one of the key assets of why we closely looked at CareCentra as a partner was because they have over a 3-year study demonstrating that they're able to achieve these outcomes with only 12 escalations on average per month per 1,000 patients that they're managing. So only 12 notifications needing clinical, engagement for 1,000 patients per month is a very, very small data demand in comparison to just collecting vast troves of information or data and trying to find the signal and the noise amongst, an overburdened care team that is trying to do the best they can in the ways that they're capable. So it's being able to acknowledge what is an appropriate clinical threshold for escalation in that data, what defines that, having input from care team members to clarify that, and then making sure there's clear integration into electronic health records so that it does not disrupt workflow. No one should have to log into a separate portal to look at various data diagrams of what's going on for each individual patient. The things that need to be put in front of care team members needs to be the things that they need to take clinical action on, and it's in a modality that they clearly understand and isn't disruptive.
And I think that's a very good point to make. When I personally think about different interventions to consider, at the VA or otherwise, how it's integrated back into my workflow, particularly, is it entering the electronic medical record in some fashion, is a major issue for me and for many other people. If you have to open, 5 other windows just to accomplish one of these things, the utility is going to decrease. So, and I'm going to pivot a little bit and talk about a few of the other things that we've done at the VA. One of them is something that both me and Cole have worked on a fair amount. It's called e-screening, and this is a tool that can be used both for direct clinical purposes, but it also can assist indirectly with some of the administrative burden facing providers and other care team members, which I think is kind of a unique location to be in. We have many metrics that we have to meet, and Cole does more work in primary care than me, but the ability to get some of these metrics completed by the patient while they're at their home can be very important. And one of the good things that e-screening does is that it integrates directly into Vista CPRS.
Cole, do you want to add anything to that?
Well, I think it speaks to, what are the clear barriers and challenges when we're trying to do stuff remotely, right? Or do anything to help support population management, individual high-risk patient management, is we have to address the data burden, and we have to address the interface. And the interface is not just for the clinician and care team, it's for the patient, right? So we don't want hundreds of notifications and creating passing the notification burden on to the patient either. There has to be an intelligent way by which we triage how and when and in what manner do we engage with our patients. And in the same way, think thoughtfully through that as we think about population management and prevention on the clinical care team level. So, when care at home is occurring, it's actually a continuum, and it's a loop back and forth between those two environments that we have to actually be mindful of and design around.
Yeah, I think something that you both have said in different ways, but a couple of times, is the importance of the balance of the notifications, the data influx, both for the clinician and for the patient. I think those are really important things to balance. We actually have a question here. So for this is off the cuff, so not any of our any of the things we talked about so far, but for each home health tech, what coordination has been performed with individuals or with the healthcare team to ensure that any results are understood, trusted, and acted upon? I know it's a long question.
Well, I mean, when we're talking about tech, like there's two, there are more than two worlds, but there are two big worlds that I think we need to acknowledge that live in different levels of certainty, right? You have the research world where we're doing clinical trials, we're doing assessments, we have material that might not be FDA approved yet. It's something that needs to go through validation, et cetera. And that world exists, and there's a different level of like thoroughness and intensity that absolutely needs to be taken in that case. And then you have the realm which is what we're focused on here in this conversation, which is around operations, about things that have already been clinically validated, already been researched, already have been shown to have that consistency and level of effectiveness for multiple studies across periods of time. And we aren't here to reprove that gravity exists, right? We're here to implement a quality improvement opportunity for things that have already been proven to improve outcomes, reduce costs, improve convenience. So the aspect of, so how do we reassure the health ecosystem and the culture that exists that this is something that can be used and is valuable? And reassurance, I think, comes with multiple modalities of communication, right? So you can educate team members about the current evidence, about the robustness of it. But what I've found more and more consistently is, yes, that information is absolutely important, needs to be a part of it. What's most important is that we're selecting technology and solutions that aren't completely disruptive to care flow, that allow people to look at that information as if it was care being provided in the office or in the hospital, because the equipment has been validated to basically express that it is the same, equal, or better than what you have in those settings. So when they see it, it should be taken as such. But if people have questions, doubts, validation issues, those are conversations where you're able to share the research that exists and have debate, healthy debate about effectiveness. But in the operations side of the thing, that question's a little bit easier to answer, because we wouldn't take on that project for population management of a health system without some evidence to justify the intervention.
Well, I think, it's kind of easier sometimes just to use examples, but I mean, if somebody has, I don't know, blood pressure readings at home that are incredibly discordant from what you're doing in the office, I mean, a very simple validation step that's very commonly done is just bring it in. And then if your machine gives the same reading that our machine does in the office, then at least it's probably trustworthy. But I think there's also a point to make about how devices are selected. And I think that kind of gets into the solicited versus unsolicited data. And, there's, the FDA approved class of devices, and then there's kind of like the lifestyle kind of devices that can still give valuable information, but the data has to be, you can't just blindly trust it necessarily. You're going to want to have some corroboration.
Yeah, and so admittedly, this next question will really push you guys out of your day-to-day world and comfort zone. But there's a question that came in about pediatric care. Do you see this being adopted in pediatrics or do you see less people less inclined to adopt because they are pediatrics?
I think it's absolutely. So I'm a family doctor too. So I like this absolutely is going to be taken up in pediatrics. I mean, one I think more classic example is post pediatric surgery, right? You have rehabilitation, and one of the things with children that are unique in that setting is needing the aspect of play, right, as a part of that rehabilitation. Now, if you have smart devices that are wearables that can assess, almost in an ambient manner, not almost, but in an ambient manner, how they're actually playing, what the differences in degrees of flexion, extension, rotation, and how they're progressing in their rehab, and do it in a setting that the child is comfortable in, where they're able to be more progressive in their actions. That's just one example, but I truly believe it's, when we're trying to provide therapy to anyone, children included, if they are in an area where they feel comfortable, they feel safe, there is a much higher propensity of them to engage in those activities than in settings where they might be more fearful or have more anxiety. So it's, how do we address the knowns here through a technological convenience to allow people to participate in a setting that they live in, rather than one that we're fabricating.
Mhm.
And I think, full disclosure, I'm an internal medicine physician, and I've found over the years that children are not just small adults. But I do think there's still plenty of examples, particularly with, think about type 1 diabetes, and, things like continuous glucose monitors that will help, both the family and the care team better understand kind of the fluctuations involved in that. I think the other thing to point out is, children are going to be kind of similar to, some geriatric populations, where if there's like dialogue back and forth, probably that dialogue is going to be coming from, in the case of kids, from the parents. In the case of older adults, it might be, a child who's doing the communication on behalf of that patient. So just a quick call out there.
Yeah, I feel like you both are trying to set me up here, but you're the panelist. So Cole leaned into something that made me think about virtual reality, right? And not just pediatrics, but adults with at-home PT. And then Blake, I'm a type 1 diabetic that uses a continuous glucose monitor. So certainly see the value, and then can tell you even personal experiences about data overload and what we do with that, both as a provider and the patient. Question that I know that you, Cole, I've heard you respond to, and you even talked about this a little bit in early on, but just to call it out specifically, with staffing challenges in hospitals, is there an indication that home monitoring will be adopted more?
So it's a complicated question because it depends on the reimbursement framework, and I hate to say that, but in the private sector, it very much is, right? There's policy out there that is allowed for reimbursement for things like hospital at home. There is definitely remote patient monitoring reimbursement that exists in the private sector, and I say that just for sustainability purposes, but you can't ignore the business end of how these things would function, right? But acknowledging that those reimbursements exist in the private sector, in the VA, we get funded, and we're able to use these funds to do what we think and the evidence shows is the right thing to do for our veterans. So we're very fortunate to be able to do that consistently wherever we can. So the answer to that is absolutely, right. If we're able to hire people to have or to hire and establish a virtual triage center or monitoring center, think about that across the country, right? We have different time zones. We have longer periods of time where we can have people monitor, remote patient monitoring elements. And by monitoring remote patient monitoring effects, be it more intense care, be it chronic disease, as long as the monitoring evaluation is triaged based on what is clinically relevant and isn't just a dump of data that you're watching a stream go by throughout the day, this is very, very practical. The example that I provided about the care centra intervention or solution, 12 escalations per 1,000 patients a month. Imagine having a virtual solution where you have a pharmacist that is trained in chronic disease management and is capable of fulfilling refill requests in real time, and having a virtual center that is made up of 3 pharmacists. How many thousands of patients would they be able to monitor remotely to help prevent people from entering the hospital, right? It doesn't mean that this states that everything can be done virtually. I don't think that that's possible, particularly in the hospital at home scenarios. You need to have people to be able to physically go out and evaluate higher acuity needs, without a doubt. But it sure as heck is going to help us with supplementing care opportunities where we aren't able to physically hire for the entire care delivery model that we traditionally provide in person. I think this creates an opportunity for us to have an honest reality check of what could and safely and evidence-based be done virtually, and how do we utilize that knowledge and insight to strategize in areas where we can't fully staff just in person, to leverage that care model as much as we can with the staff that we do have in person. I think it's not only going to occur, but it's going to be necessary as we continue to struggle with staffing and space across the country in healthcare.
I do want to point out, though, that, I think, it's important to acknowledge that there's not just like a magic hospital at home or magic RPM button where you have this care delivered and you don't need FTE dedicated to do it, and it's super easy and the technology works perfectly every time and the patients know how it works. I've experienced firsthand many times that it can be a very difficult process, especially when you're talking about getting devices to and from patients. And that certainly should not be overlooked as people try to investigate some of these processes. But having said that, I do think that hospital at home in particular has a pretty clear benefit opportunity for fewer FTE per patient, just by them being in their home.
Fewer and different, right? Cole, you mentioned PharmDs. Of course, I'm partial to that because now you guys are giving me that thing to talk about as well. But pharmacists are less expensive than MDs. So are there ways that you can use differently licensed clinicians and leverage this? But I hear what you're saying 100%. Blake, we are certainly seeing and experiencing that where there's this steep learning curve, right? And hopefully that learning curve for implementation will actually become a new plateau for us to launch from in using these devices and things at home. But that 100% something we have to keep in mind and think about when we're thinking about the runway.
And I think that, I forget one of the presenters earlier, focusing on SMS communication. I think that's an important point where if you're utilizing technology, assuming it's accurate, that they already have, does make it, a significantly lower burden to implement. The other thing I want to point out, though, is, I think in the VA, there's a kind of advantage that we have with regards to licensing across state lines, which is not going to be the same in the private sector.
That's true. Do you want to talk a little bit more about that, Cole? I know you and I have talked about that some and how we don't utilize that as much as we.
Yeah. So we the VA has basically federal supremacy. So we're able to, once we have a clinician license in one of the states or entities across the U.S., they're able to provide care, provision care via telemedicine, virtually, in person, at any of those VA-specific facilities. So that's a huge advantage, right? Because then you're not having to worry about whether one state provides reciprocity or not for licensing, the additional administrative burden for those elements. So that's huge, right? But obviously, you see scaling up of these virtual care models in the private sector as well, and they've been able to work through some of these issues, although very burdensome in many circumstances, to provide those services. So, but it makes it more complicated for sure.
So as we're thinking about the future, are there other measures, blood parameters, biomarkers, things like that that would supplement what we currently use or call as basic vitals that can help with that health at home model?
Well, I think that digital biomarkers are going to be absolutely critical moving forward, and that's where when we look at the schema of digital health, right? Those are things that are not requiring FDA evaluation. They're for health promotion purposes, lifestyle management, may be health related. That there's a huge opportunity to look at what are and research what are things that can then move from digital health to digital medicine or even digital therapeutics by being able to clearly show high levels of correlation of a digital biomarker with a particular clinical endpoint. Examples that I would kind of bring up are, one of the biggest ones is sleep, right?
Mm-hmm.
If we're able to identify and have better, valid accuracy of sleep levels, there's huge impact on chronic disease management, mental health, that is going to be, I think, in the future utilized more readily and should be to help support health promotion. Physical activity is also one of those other robustly studied to improve outcomes. And we're not talking having to go to the gym every day. I mean, it's just brisk walking for short periods of time have shown huge impact. And how do we tether digital biomarkers with patient specified goals with appropriate incentives to match? And I don't see digital biomarkers as an entity of itself. It has to be a part of this connected package of how do we provide you an opportunity to get feedback and insight to work towards a goal and have the appropriate incentives that mean something to you to help you achieve it in a way that makes sense. And then when it's clinically appropriate, that signal through the noise is able to pull in the care team to say, hey, there's an increased risk and concern here that you might want to further evaluate. It's time to engage, right? So I think this is going to be a consistent interplay, and the more studies that occur, I think will emphasize not just a individual digital biomarker, but a stacking and a cluster of digital biomarkers that correlate, that lift the sensitivity and specificity opportunities that exist, even compared to clinical screeners that we have today in and of itself.
And I think, I mean, there are some, specific digital biomarkers that are kind of becoming more mainstream. Heart rate variability has, implications in a lot of disease states, including, cardiac as well as mental health conditions. And, the one thing I'll point out about that is, if you just present to a clinician, this is their heart rate variability, I mean, most people are gonna be like, I don't know what that means.
Right.
So you have to couple it with, clinical significance for most people until things like that become more mainstream.
Yeah, so I've heard that a few times too, like what you said, and Cole, I think you mentioned earlier as well, is the importance of education, right? Making sure people understand what terms mean, what evidence already exists, and how we can think about moving these things forward. Because sometimes those are unnecessary barriers to implementation and adoption that I think is important to think about. So leading into that, as we move forward, what are some of the most significant and pressing barriers and challenges?
I think we touched on a few of them here. The biggest challenges and barriers that I see are definitely what you just mentioned, which is translation on both sides, right? So I'm thinking in terms of someone that's trying to do rehabilitation, physical rehabilitation in the home, right? telling them that you can only move your arm to 120 degrees and you should be at 170 degrees or 160 degrees isn't going to mean anything to them. Like what's going to mean something to them is you're able to put a can on top of a 6-foot shelf, right? You're able to put away your dishes in different average closet size given your height. Like it's how do you make this relatable to the quality of life and the life that we live every single day? And it's the same thing, translated into the clinical world when we're talking about these different digital biomarkers or data. So it's education, it's making sure that we're only putting things in front of care teams that they can take action on in a way that fits elegantly into their workflow. And then the last part here is going to be about how do we try to create a unified platform around this, right? So we don't want to have this quilted patchwork of 50 different solutions, all with independent elements. We want to be mindful of notifications and triaging them on both sides of the house. The only way we're going to be able to do that is by we might have a veteran patient on 3 different devices that are supporting them in the home. And how do we sequence notification and engagement in a way that's rational and triaged? And some kind of unified platform is going to be needed so that we don't overwhelm either the patient or the care team, given the explosion of opportunity that's going to exist in this area.
I think that one of the biggest barriers is likely going to be in all of these things, underestimating the infrastructure needs to do this well. And there might be a certain federal healthcare agency that sometimes it's difficult to hire people, remain anonymous. And so when we start talking about implementing these programs, and to do that first, you have to have dedicated staff to monitor these, and everyone is already stretched so thin. So there's going to be a lot of barriers and pushback, from people who are saying, well, my staff is already overwhelmed. I can't add this other thing to them. And then it's going to take too long to hire people. So, and I'm not saying I have an answer to this, but I think that's going to be a big barrier. And again, the critical importance of appropriate integration into the electronic medical record and into an actual clinical workflow. It's not easy,
No,
but you have to do it.
that's right. No, I agree. I appreciate just bringing that up so that we as a field, as a community, as people on this call, as people as a part of this effort in healthcare and the broader tech community, even think about some of the everyday practical challenges, right? It's not just developing great technology. It's how do we actually implement it, like we talked about. So I'm going to throw you a wildcard question. We probably will address this even more throughout the day, so don't feel significant pressure. But do you think that remote monitoring, let me ask you this way. What do you think the impact of remote monitoring on healthcare cost will be?
That's a great question. So to me, healthcare costs has to be clearly defined, right? Because I think we kind of mix that up with utilization and potential for prevention, and we don't actually look at the entire care pathway like we should. So if we actually look at the entire care pathway, which doesn't mean hospital admissions only or ER visits only, but number of specialty outpatient visits, primary care outpatient visits, number of phone calls, number of virtual visits, all of these things actually taking into account care that's being rendered outside of your particular healthcare system, amount of time for the patient or veteran in our case spent going to all of these places to get care rendered. I mean, costing gas, loss in being able to show up to work because they have to take days off. All of these things need to be accounted for when we actually think about real costs. It's not just cost to the healthcare system, it's cost to the patient. And how do we reduce or avoid costs if care could be rendered in the home? and there's not just remote monitoring, because I think that's where some of this stuff is. That's first phase, right? We monitor things, but then there needs to be an opportunity for clinical action. So I think the most classic example of this is related to COPD exacerbation. I mean, the American Lung Association has made it clear if you have certain symptoms, right, you can have a medicine toolbox that includes azithromycin and prednisone that a patient is trained on to be able to reach out once the symptoms hit a certain level and take the medications that they already have available. They don't have to leave their home to go pick them up. They don't have to be mailed the next day. They actually get immediate help. So I think the layered component of cost savings is not just identify the problem, but how do we make the intervention for treatment just as convenient where the evidence exists to do so? And when you combine those two things, not just one of them, you're going to see a dramatic improvement in cost avoidance, not just for the health system, but also for the patient. And more studies in this area are required to more fully demonstrate that. But that's definitely, I think, where this ends up.
I'm going to give a much shorter answer. I think it's going to decrease costs.
Okay, tell me more.
So, I mean, I think that, again, I keep picking on hospital at home, but I'm not really picking on because I'm supporting it. But I think that if you can get the appropriate investment in the infrastructure and the staff to do it, you can make your staff, you can touch more people with fewer staff, I think is one thing. But then the other thing to consider is if you just look at the facility costs alone and how much, just a single night in a hospital costs. I mean, you can hire a lot of people for the savings that can, arise from fewer days in the actual hospital. I think that's one specific example. That's probably going to be the easiest to prove.
That makes sense. So, question about at-home monitoring specific. Thoughts on things like COVID at-home testing, and what's the success look like? What does success look like for that type of approach, or even pregnancy testing? Or
so COVID home testing, it's actually something I've done a lot of work on, and specifically looking at patient-generated text messages to their clinical teams. We kind of found that there was a fairly significant decrease in the amount of internal testing that was being done in our facilities. It's because everybody's doing it at home and nobody's reporting it to the hospital or any other way other than unstructured text. And because of that, it is not easily found without using sometimes fairly sophisticated natural language processing techniques. So do I think it's valuable? Absolutely. I think that, people can get diagnoses faster, but it has to be coupled with a faster path to intervention as well, though, because, if you have a COVID test that's positive and you don't have any way to get treatment or change anything, why does it matter?
That's a great question.
Yeah, I think that, COVID or frankly, any condition. I mean, you look at, recent studies as it relates to like prenatal risk and how important it is when pregnant to really have a more fine-tuned awareness of blood pressure and its impact on outcomes. All of these interventions require us to be aware and appreciative of the risks of monitoring, right? So the sensitivity and specificity of these evaluative tools has to be considered. I don't, there are questions that need to be asked of should this be, so I'm a family doc, I'm a preventive medicine physician as well. And one of the key elements of preventive medicine is you treat a population differently than you would treat necessarily an individual. Population, if you're going to be targeting people with screener questions or evaluation, in most cases, there has to be some element of risk identified for that to be as beneficial as possible. Now, to give a specific example of why we have to be mindful of these things is that when you look at evidence related to U.S. Prevent Task Force, when they're evaluating whether we screen people with PHQ-9s related to depression and potentially suicidality, it clearly shows that if you don't have the staff, you don't have the resources to help those individuals that you identify, you have to question whether you should be screening. Because the element that we have to consider with this is that if we identify people in earlier stages, for example, not everybody necessarily is going to have the extreme, but even in earlier stages that require clinical intervention, do we have the staff to take on all of these new volumes of patients that are lower acuity? And is that going to prevent access to those with higher acuity that need to be seen more readily, right? So with all of this, not just COVID related, but any kind of remote patient monitoring, that population-based approach needs to be taken, thinking about sensitivity, specificity, and risk of access that could occur.
So, I mean, I think one other thing to consider, and this is kind of a little bit off topic, I guess. I think we can't ignore, there's already fairly significant care gaps and inequity. And if we start saying that we're going to try and solve these problems with technology that is not equally accessible across the population, I think that's something that needs to be considered as well, obviously. I think it's pretty easy to, sit in the ivory tower of academia and, assume that everyone can have the same access to all these tools, but I think we all know that's not the case.
Yeah, unintentional and creating inequity unintentionally, I think, is something. And to some degree, how much at this point can we actually call it unintentional if we're aware that we need to be thinking about these things? That kind of approach is definitely complicated, but important. Not complicated, complex conversation, but important conversation. So we have 6 minutes left. I'm going to drop one more complex question. But when we talk about at-home testing, does it matter, or how does it matter that electronic health records may or may not be able to ingest the results in the near term, but even for some in the long term, as sometimes they're not incredibly flexible systems? Does that matter, and how does it matter? So,
I'm going to use some data from my own research, and back to the COVID test. I found that 98% of the tests that were being self-reported via secure messaging was not otherwise found in the structured data elements. And so when you start thinking about, I'm going to use another example. So much care occurs that is stored as unstructured data. And there's so much of it that it becomes almost impossible to process. And so that's why it's important, is because all these little tidbits, if they're not put into structured data, become so much more difficult to keep up with, and you miss things.
I think the bottom line is when someone needs help, we need to have a consistent and reliable way to know when they need it to help them, right? 911, someone needs help. That system needs to be placed and accessible, and someone's going to pick up on the other side to help, right? And labs are the same way. If we're going to be doing something that assesses someone's, potential health outcomes, right? You need to be able to obtain that information in a reliable way where someone's going to pick up the phone. And picking up the phone in the case related to electronic health records is being able to present that data in a way that shows a level of necessary urgency of response. Because when we look at all of the different notifications that providers and care team members receive in a day, there are signals in the electronic health record system that says, hey, this is urgent because it's abnormal and may need immediate clinical care action. When things are not connected in that way and outside of that workflow, outside of the appropriate triaging that needs someone to pick up the phone or reach out to the patient and get them the help they need, it's not an inconvenience, it's a harm. It's a patient safety concern. It is not something that should ever be taken lightly, and could in fact cause significant harm or death to a patient when they need timely action. So it is of utmost critical demand that any solution that's obtaining information that could save someone's life, prevent a catastrophic event that needs timely clinical action, is putting that information in a way that is within a system that's set up to handle those critical needs.
3 minutes left. If there's one thing you guys each individually want people to walk away from this session with, what is that one thing?
Integrate into the EMR.
I think it's work with co-designing teams as early as possible, including patients, providers, and making sure that everyone has a word in the design to make it most successful. More often than not, these are afterthoughts that occur when technology is found that everyone gets excited about. But without appropriate co-design for applicability, these efforts could actually worsen conditions for a system that's already strained.
Well said. Okay. 2 minutes left. Really appreciate you guys. Thank you so much for your time, for your insight, for the work that you do every single day. Because if you weren't doing that work, you wouldn't have had the expertise or experience to share with the group. So excited and honored to get to be your colleagues, but we get to do this presentation together as well. But thank you. I want to say that. So Sheila, I'm going to hand it back over to you for the next session.
Thank you so much, Anne and Cole and Blake, for this really engaging session. Clearly, we got a lot of questions in our resource inbox, so I really appreciate the engagement here from the audience. As we